All right, so I think the audio is back now. Can you hear now? Can you hear me? Quick feedback, quick feedback. Can you hear me? Can you hear me now? Now fine, okay. So hi Usama, hi Priyanshi, hi Sudarshan, hi everyone who is down there, hi Hussein. Right, so as I was saying, last week we did our BLS series. तो हमने abdominal trauma शुरू किया था. We did a solid organ injuries का एक session किया है. We have covered splenic injuries and the liver injuries there. I'll be covering abdominal trauma in detail. So I'll be talking about the pancreatic injuries. I'll be talking about the other components like the bowel injuries, the colorectal injuries, the great vessels of the abdomen. All that will be covered in the upcoming series. Okay. Okay. So with that into consideration, today I'll build a little bit around the abdominal trauma only. So I'm not going to go into the organ specific injuries today. We'll talk about the abdominal component itself. Okay. So what I want to discuss today is about two important things. The first one is a concept which is called as the damage control surgery, right? So we have a concept which is called as the damage control surgery. So I'll be talking about the damage control surgery. Now, damage control surgery is a concept. You need to understand that when would you like to go ahead with damage control surgery. Now, as the name itself suggests, it is a surgery that you're going to do to salvage a situation, right? Where you don't have any other, go, or you don't have any other option. You're going to stick to a protocol which is called as damage control surgery. The opposite of damage control surgery is what we call as an ETC, that is called as an early total care. So any patient who has come to you with trauma, the decision is whether you're going to operate that particular patient with an intent to completely reverse the situation or to manage a situation. That means, let's say patient came with abdominal trauma and there was some injury in the colon. I did a colostomy, end of discussion, and later on you can go with reversal, right? On the other hand, if a patient has come to you with there is a thoracic injury, there's an abdominal injury, where there's a liver injury, there's a splenic injury, there's a bowel injury, the multiple other structures which are injured. Now, you cannot sit and repair each individual structure because it is going to cause more time. It is going to cause longer duration of surgery, longer exposure, more blood loss, and all these will give rise to our lethal triad of trauma. You remember we spoke about lethal triad of trauma. What is lethal triad of trauma? It is metabolic acidosis because of excessive volume loss where there is decrease in tissue perfusion. Decrease in tissue perfusion will result in conversion of aerobic respiration to anaerobic respiration, where the end product is lactic acid. Patient will develop metabolic acidosis. Excessive blood loss will cause decrease in calorigenesis, which is called as hypothermia. And that excessive blood loss will also result in coagulopathy. And all these three put together is what we call as lethal triad of trauma. So, any patient who has come with multiple organ injuries and you try to cover and completely repair every single structure, you're causing greater duration, greater exposure, greater loss, including blood loss, temperature loss, and that will result in lethal triad of trauma. To prevent lethal triad of trauma, we have a concept which is called as a damage control surgery. Now, usually in our discussion, I will discuss this in two components. One, I'll be calling it as the stages of the damage control surgery. Another one is the phases of the damage control surgery. So we saw stage and phase. They're almost same. There's nothing difference about the stage and phase, but this is how you interpret it is what we are going to look into it. So we have two different components, the stage of the damage control surgery and the phase of the damage control surgery, right? So let's start discussion with the stage first. So when you say stage, we have the stage one. The stage one of the damage control surgery is basically a patient selection. Now in the patient selection, we need to know that which patient would require a damage control surgery and which patient can be get over by early total care. So my basic objective is to find out that who requires a damage control surgery and who would require an early total care. The stage one is basically patient selection. Now, once you've selected the patient, the stage two, it is your primary exploration. It is going to be your primary exploration. We'll take the patient for primary exploration, right? Hi Mansoor, good evening. So in the primary exploration, what is the goal that we are going to set? Now the goal for the primary exploration, number one, it is to control the ongoing hemorrhage. So it is to control the hemorrhage. Second, prevent any further contamination. Prevent any further contamination. Now, when we talk about any further contamination, in the further contamination, so say control hemorrhage and prevent any further contamination. When you talk about prevention of further contamination, that means I do not want the bile that is leaking due to an injury to be collected into the abdomen. I will make a provision for the bile to be excreted out, or I can say it should be collected outside the abdominal cavity. Same, if it's a fecal soiling, I'll give a good wash and make sure the bowel that is injured, either I'll do a repair or I'll do a colostomy or an ileostomy so that the content does not continue to accumulate into the abdomen. As simple as that. And that is what we call it as prevention of, or I can say prevent any further contamination. So I'm going to go ahead with control of hemorrhage and prevent any further contamination. So these are the two important goals of your primary exploration. Every patient who has undergone primary exploration, I'm not going to go with closure of the abdominal wall. So here we are going to go ahead with temporary abdominal wall closure. Here we'll take the patient for temporary abdominal wall closure. So when you say a temporary abdominal wall closure, you can put a stay suture which is going to be very lax so that you can easily re-explore it. Or you can keep the entire wound open, cover it with a plastic bag which is also called as a Bogota's bag, where it is just, see, the objective of covering that area is to prevent the internal environment from communicating from an external environment. I don't want the exchange of the pathogens or the materials that gonna happen. So to prevent it, I'm just going to put the bag. Why am I not closing it? We'll talk about a very important concept that is called as an abdominal compartment syndrome. To prevent it, I am not going to close immediately. So temporary abdominal wall closure has two important reasons. One, I would require a re-exploration. Second, to prevent abdominal compartment syndrome. As simple as that. Now, once I have done my primary exploration, I will now enter into stage 3. And stage 3 is to shift the patient to the ICU. And here we will take the patient for ICU care. Now, what is the goal of the ICU care? Now, when you take the patient for ICU, the ICU care is going to be from 24 to 48 hours. So for next 24 to 48 hours, I'm going to observe the patient in the ICU. Now, what is the goal that we have set? In an ICU care, the goal that we are going to set across here, number one, in terms of ICU care, it is basically to correct any ongoing coagulopathy. Correct ongoing coagulopathy. Treat and prevent hypothermia. Treat and prevent hypothermia. It is to correct coagulopathy, to treat and prevent hypothermia. There are two important aspects that you are going to take the patient for an ICU care. Usually after 24 to 48 hours, once the patient stabilizes, we're now going to enter into stage 4, and stage 4 is what we call it as re-exploration. Now, this re-exploration stage is also called as the stage of the definitive surgery. It is the definitive surgery. Now, in a definitive surgery, obviously, what is the goal? It is to correct the anatomy. The single most important goal that you're going to keep here, it is to correct the anatomy. And here also, I am not going to go ahead with definitive abdominal wall closure. I'll keep here with temporary abdominal wall closure. Here also, I'm keeping temporary abdominal wall closure because to prevent abdominal compartment syndrome. So temporary abdominal wall closure. We'll go ahead with temporary abdominal wall closure. We'll go ahead with temporary abdominal wall closure. Now, once the patient stabilizes, we now enter into stage 5. and stage 5 is abdominal closure, and this is what we call it as a definitive abdominal closure. Okay. So when you look at the stages of the damage control surgery, in the first stage was of patient selection. You should know which patient would require a damage control surgery and which patient would require an early total care. That was your stage number 1. The second stage is to take the patient for primary exploration. The goal of the primary exploration here, it is to control the ongoing hemorrhage which is active and also prevent any further contamination. You should not allow any contaminant to get accumulated into the abdomen. I should make a provision so that it is going to be draining out of the abdominal cavity. As simple as that. Once you're done, I'm not going to close the abdominal wall for complete. I'm just going to put a temporary abdominal wall closure. That could be because of that could be achieved by putting a stay suture or a Bagota's bag or a plastic wrap. Anything and everything is acceptable down here. Once you're done there, shift the patient to ICU. That is a stage 3. In the ICU, you'll put the patient for approximately 24 to 48 hours. The goal of ICU, number 1, to correct ongoing coagulopathies, prevent and treat hypothermia the patient has experienced. Shift the patient to the next stage. That is going to be your stage 4, which is re-exploration. Now, the objective here is to correct all the anatomical components which were disrupted, and finally to stage 5, which is a definitive abdominal wall closure. Right now, these are the various stages of your damage control surgery. Now, similar sounding terms which we'll be using, which is called as the phase of the damage control surgery. Nothing spectacular. It is the same thing with a different tinge of words that are used. So we have something called as the phase 0. Now phase 0 is your patient selection. Phase 0 is your patient selection, right? So after you have done the patient selection, you will now enter into phase 1. Now what is phase 1 here? The phase 1 is going to be your emergency laparotomy. It is going to be your emergency laparotomy, or also called as the primary exploration. Now from the phase 1, you will now go into phase 2. You will now enter into phase 2. Now in the phase 2, it is your ICU care. Phase 2 is going to be your ICU care. From the phase 2, you will now go into the final one, which is called as the phase 3, and the phase 3 is a phase of re-exploration. Nothing has changed. It is only the wordings that is going to be put across here, right? Now, if you look at each individual, now why we have given us phases, no, to give you a particular objective behind this. Okay. Now, when you talk about phase 1, nothing spectacular about it, obviously a patient selection. In phase 1, it is emergency laparotomy. We know the goals. It is to control the hemorrhage and prevent any further contamination. Same is there. Here, we'll go ahead with temporary abdominal wall closure. It will be addressed with your temporary abdominal wall closure. The ICU phase is going to last same as 24 to 48 hours, and it is to correct the lethal triad. It is to correct the lethal triad. The last one is the phase of re-exploration, and the phase of re-exploration, it is to address, or it is to correct the anatomy. It is to correct the anatomy. As simple as that, right? So just do not get confused between the stages and the phases of the damage control surgery. That are two similar sounding words that they'll be using it. So you need to understand, especially if you're going with a competitive exam, no, everything you know that you understand it, but from the exam perspective, they might use the word stage or they might use the word phase. So this is your staging and the phase of your damage control surgery. Now, I've been using a word which is called as an abdominal compartment syndrome. I'm saying that, you want to prevent it, so hence you're doing all this blah, blah, blah. So we'll try to understand that what is this abdominal compartment syndrome, right? So we're talking about something called as the abdominal. We'll talk about the abdominal compartment syndrome. We talk about something called as the abdominal compartment syndrome. So anywhere when you talk about the word compartment syndrome, that means there's a constant increase in pressure in that particular space, and it is a confined space. It is not able to regulate. Hence, it is called as a compartment syndrome, right? Now, when you talk about what are the causes of the abdominal compartment syndrome, so when you look at the abdominal compartment syndrome, one is going to be your abdominal trauma. So post-trauma, there is injury. That injury will cause inflammation, rubercaloidal tumor. There'll be edema. Because of edema of the bowel, it starts to swell up, but the abdomen cannot distend after a point. Hence, the pressure will start increasing, resulting in abdominal compartment syndrome. Now, along with abdominal trauma, the other ones are, it is seen secondary to burns, that is significant burns. It is seen secondary to significant burns. Now, when I say significant burns, as by definition, it is more than or equal to 15% of the total body surface area burnt is what we call it as significant burn. And all significant burns, because there will be severe inflammation, and that will result in development of gut edema. That will result in the development of gut edema, and this gut edema will result in abdominal compartment syndrome. Now, along with that, especially in your end-stage liver diseases and all, where you have significant ascites, so we use the word massive ascites. It is secondary to massive ascites and bowel obstruction. And secondary to bowel obstruction, right? So one that results in development of abdominal compartment syndrome is secondary to a trauma. There's significant burns due to a massive ascites and secondary to a bowel obstruction. All these can result in abdominal compartment syndrome, right? Now, once this happens, how does it vary, or what impact does it cause? So we'll talk about the pathophysiology. We'll talk about the pathophysiology of the abdominal compartment syndrome. Now, in order to call as an abdominal compartment syndrome, first you should know what are the intra-abdominal pressures usually look like, right? So when you talk about the intra-abdominal pressures, in intra-abdominal pressures, we have something called as intra-abdominal hypertension. Intra-abdominal hypertension. So anywhere the word hypertension indicates increase in pressure, so here also it means the same. So it's increase in intra-abdominal pressure, we call it as intra-abdominal hypertension, right? So what is this intra-abdominal hypertension? When you look at the various grading components of the intra-abdominal hypertension, so when you say it is grade 1, so if you have a grade 1 intra-abdominal hypertension, the intra-abdominal pressure, IAP's intra-abdominal pressure, is anywhere between 12 to 15 millimeters of mercury. Then we call it as grade 1 intra-abdominal hypertension. Now, if the pressure increases, it goes to grade 2. And in grade 2, the intra-abdominal pressure is going to be between 16 to 20 millimeters of mercury. It is going to be 16 to 20 millimeters of mercury. Then you have the grade 3 intra-abdominal hypertension. So here the intra-abdominal pressure is going to be 21 to 25 millimeters of mercury. It is 21 to 25 millimeters of mercury. That is going to be grade 3. And the last one that you have is what we call it as the grade 4 intra-abdominal hypertension, where intra-abdominal pressure is more than 25 millimeters of mercury. It's going to be more than 25 millimeters of mercury, right? So when would you use the word abdominal compartment syndrome? When would you call it the patient is having abdominal compartment syndrome? So when do you use the word as the abdominal compartment syndrome? Where you have intra-abdominal pressure more than 20 millimeters of mercury. When an IAP is more than 20 millimeters of mercury with a new organ dysfunction. With a new organ dysfunction. So here we're talking about intra-abdominal organ. So it could be a liver dysfunction, it could be a kidney dysfunction, anything, right? So intra-abdominal pressure more than 20 with new organ dysfunction, then you will call it as intra-abdominal compartment syndrome, right? So just increase in pressure is only called as intra-abdominal hypertension. When you talk about abdominal compartment syndrome, this needs to have a pressure which is more than of 20. At the same time, there has to be a new organ dysfunction. If this criteria is satisfied, I would say patient is having abdominal compartment syndrome. Now, how would a patient present to you with abdominal compartment syndrome? So talk about the clinical presentation. The clinical presentation of abdominal compartment syndrome. Of the abdominal compartment syndrome. Right. So clinical features of the abdominal compartment syndrome. Right. Now here, as the pressure inside the abdomen will increase, it is going to compress various important structures. Now when I talk about the various important structures, I talk about the vessels first. So you have the IVC is there is aorta and other major vessels, right? So the easiest one to be compressed when there is increase in intra-abdominal pressure, you have three important vascular structures which are present in the abdomen: the IVC, the aorta, and the other major vessels which are supplying to the kidneys, which are supplying to the liver, which are supplying to the bowel. But again, all these originate from the aorta per se. But when you look at all these vessels, the easiest one to get compressed is going to be inferior vena cava. So you will see there will be an IVC compression. So increase in intra-abdominal pressure will result in IVC compression. Now, if the inferior vena cava is going to get compressed, if the IVC is going to get compressed, needless to tell you what will happen to the venous return to the heart. What will happen to the venous return? Which will happen to the venous return to the heart? The venous return to the heart will decrease. The venous return to the heart is going to fall significantly, right? So IVC is going to get compressed. The compression of IVC will not allow the blood to reach back into the heart. So in simple component, we're talking about here, this is the heart that we are depicting. It has got 4 chambers. And this is our IVC, which is supposed to go and give the blood here. And this IVC is going to travel through the abdomen. And let's say this is the intra-abdominal IVC that is present. So let's say this happens to be an intra-abdominal IVC which is going to be present. So I'll just mark it down here. So this is the IVC, and let's say this happens to be the aorta. So from here, the aorta is going to arise. So this is the aorta that is going to go into the abdomen. So this is the intra-abdominal aorta, right? So 2 major vessels that we have. One is your IVC. This is your inferior vena cava, where the blood is going to flow towards the heart. And in the aorta, the blood is going to flow away from the heart, right? This is the basic concept that we have. Now, as there is increase in the pressure, when the abdominal compartment pressure increases, the first structure which is going to get compressed, it is going to be your inferior vena cava. When the IVC is going to get compressed, the blood going back from the IVC into the heart will decrease. So I can say the venous return to the heart is going to decrease, right? It is going to result in decrease into the venous return. Now, if the venous return decreases, what will happen to the blood in the right atria? The blood in the right atria will also decrease. Right atrial blood component. The right atrial blood will also decrease. And we all know the right atrial pressure is measured by your JVP. So I can say as the blood going into the right atria decreases, the right atrial pressure will also decrease. And the right atrial pressure is measured by jugular venous pressure. So you would see the JVP would also fall. Now, obviously, when the pressure in the right atria, because the volume of blood going into the right atria decreases, the blood coming back into the right ventricle, from there into the left atria, from into left ventricle also decrease. So I can simply say the blood going into the left ventricle decreases. That is nothing but preload to the heart. Now, if the preload to the heart will decrease, the preload determines the cardiac output of the heart. So what will happen to the cardiac output of the heart? The cardiac output. So I hope everybody knows the cardiac output is measured as preload minus afterload. If the preload decreases, obviously the cardiac output will decrease, right? So you now know, because of IVC compression, because of the IVC compression, there's decrease in venous return, there is decrease in JVP, there is decrease in cardiac output, right? Venous return decreases, preload decreases, JVP decreases, and the cardiac output decreases. Now, whenever the cardiac output in the heart will decrease, right, what will happen to systolic blood pressure? Now, as we all know, systolic blood pressure is the pressure exerted by the volume of the blood onto the lateral walls of the vessel. If here the volume decreases, obviously the systolic blood pressure will drop. If the systolic blood pressure decreases, what will happen to baroreceptors which are present in the arch of aorta? They get activated. If the baroreceptors get activated, they will release, obviously what will they cause? They cause sympathetic activity. Whenever the baroreceptors get activated, they cause the activation of sympathetic system, which will cause activation of your excessive release of catecholamines as epinephrine, norepinephrine, and their effect on the heart is going to increase. So here, like a status of shock, there will be decrease in systolic blood pressure and there will be increase in your heart rate. Osama, you are absolutely correct. So this is what the first thing is going to happen when there is an IVC compression, right? Meanwhile, as the pressure continues to mount, now it is now going to go into aorta, and here the aorta is going to result in compression. So aorta compression will result as a subsequent pathway. Aortic compression will result as a subsequent pathway, right? Now, if the aorta is going to get compressed, but okay, we'll see the aorta comes last. We will not talk about aorta first, because to compress aorta, it will take hell lot of our pressure, right? Now, as the intra-abdominal pressure increases, what will happen to diaphragm per se, right? So diaphragm is going to be pushed up. So it is going to result in the diaphragm is being pushed up. Diaphragm is going to be pushed up. Now, if the diaphragm is going to be pushed up, what is going to happen? Now, in order to understand this, let's say this is the abdominothoracic space, right? Just for the sake of understanding, we'll just interpret these two. This is how the normal side of the diaphragm is going to be present. And just for the sake of understanding, this is our lungs which are present. This is the right lung. This happens to be the left lung, and they are able to expand and they are quite normal. And this is your normal presentation, right? There could be, Hussein, yes, there could be peripheral pooling. It will result in edema. All that is just, agreed upon. If the IVC gets compressed, the blood from the lower limbs cannot be excreted. So they'll start pooling in the lower limb. Hence, they'll result in lower limb edema. But that is going to come later on. Okay? That will take some amount of more time. Now here, as the pressure inside the abdomen increases, as the intra-abdominal pressure is going to increase, as the intra-abdominal pressure is going to increase, now this is going to push the diaphragm up. So normally I would have expected the diaphragm to be at this particular point. Because of increase in pressure, the diaphragm is now being pushed to this point. Now diaphragm is being pushed because of increase in pressure. So what is now happened? The lung which is present is now forced to compress. So you have less amount of space for the lung to expand. So now I want you to compare the volume of lung that is present in the normal side. So this is in normal abdomen, and this is where you have abdominal compartment syndrome. So this is where the pressure in the abdomen has increased tremendously, and this is what we call it as the abdominal compartment syndrome, right? This is what we call it as an abdominal compartment syndrome. Now, what is going to happen? Because of this, as the diaphragm is pushing up, as the diaphragm pushes up, what are the changes that are going to happen? The first thing that you will notice, what will happen to the intrathoracic volume? What will happen to intrathoracic volume? No doubt, because of compression, the intrathoracic volume decreases. We all can understand the intrathoracic volume is going to decrease, right? If the intrathoracic volume will decrease, what will happen to the total lung capacity? What will happen to the total lung capacity? That also reduces. Now, if the lung capacity reduces, that means the amount of air going into the lung reduces. But if the amount of air going into the lung reduces, no, now you don't get enough amount of oxygen, right? If you're not getting enough amount of oxygen, what will happen? The patient will now experience a state of hypoxia. So this will result in development of hypoxia. Now, to overcome the hypoxia, what will happen to the respiratory rate? Now, patient would start to breathe faster to compensate for that air hunger. So respiratory rate will increase. It will result in tachypnea. It will result in tachypnea. Now, as the respiratory rate will increase, what else is going to happen? Now, intrathoracic volume decreases. As the volume decreases, but all the structure is still there. No? So what will happen to intrathoracic pressure? This will also causes increase in intrathoracic pressure. It will result in increase in intrathoracic pressure, right? So here you see there is decrease in intrathoracic volume, decrease in total lung capacity, causing hypoxia because inadequate amount of oxygen is going, or the air is going in. Tidal volume also reduces. The respiratory rate increases to compensate for whatever loss is there, and also result in intrathoracic pressure. Also increases intrathoracic pressure, right? Now, the last one that you're looking at, there will be compression on the aorta as well. So there will be an aortic compression. So when I talk about aortic compression, you will not see aortic compression as one single entity. To give you an objective, one of the major vessels that is going to arise from the aorta is going to be renal artery. So I can say it can result in renal artery compression. It can result in renal artery compression, just to give you one organ how it is going to influence in the abdomen. If the renal artery compression is going to happen, what will happen to renal perfusion? Obviously, the renal perfusion is going to drop. If there is decrease in renal perfusion, what is going to happen to GFR? That is a glomerular filtrate rate. So the GFR, because of decreased perfusion, will now start to fall. GFR will reduce. Now, whenever the GFR falls, what will happen? It will cause activation of renin, angiotensin, aldosterone system, which will cause increase in aldosterone. Now, as there's increase in aldosterone, what is going to happen? It will result in vasoconstriction. Activation of RAS system will result in decrease in urine output. There will be decreased urine output. Vasoconstriction will result in hypertension, and this is what we call it as the renal hypertension. This will result in renal hypertension, right? So this is how whole compensation mechanism is going to kick off for this patient, right? So in the abdominal compartment syndrome, you see the IVC compression have its own impact. Diaphragm gets pushed up, there will be intrathoracic component, and when the aorta gets compressed, example like renal artery can get compressed, and it will result in all these components. Now, if you see that there is increase in blood pressure, that indicates compensation, but there's decrease in blood pressure, that is going to be an early compartment syndrome. So in an early abdominal compartment syndrome, you will see hypotension, but if there is an organ injury, when you talk about renal hypertension, it is because of damage in the kidney, no? So this hypertension indicates renal damage, and that renal damage indicates there is an organ injury. So intra-abdominal pressure more than 20 with an organ injury is a classical example of abdominal compartment syndrome. So do not goof up with that, right? So this is going to be very, very, very important. Everybody's clear? Now, how do you manage your patient of abdominal compartment? See, in order to evaluate for your abdominal compartment syndrome, in terms of investigation, I need to measure the intra-abdominal pressure. So you can use an abdominal tonometer. You can use an abdominal tonometer. You can measure the bladder pressure. Which will indirectly tell you the pressure inside the abdomen. Either use an abdominal tonometer, or you're going to measure the bladder pressure. Both of them will tell you whether there is increase in intra-abdominal pressure or not. Now, if they measure to be more than 20, along with that there is an evidence of an organ injury, that goes in abdominal compartment syndrome. So how would you manage? Now, in the management of abdominal compartment syndrome, the first one is always to correct the underlying component. So correct acidosis. Start the patient on IV fluids and plan for decompressive laparotomy. Plan for decompressive laparotomy. Right? Correct the acidosis, go with fluid resuscitation, and plan for decompressive laparotomy. Right? So this is what you will do in your abdominal compartment syndrome. Right? The concepts are quite clear and clean, but this is something that you cannot afford to miss out in your abdominal injuries. Now, just to keep things into rolling, I will quickly talk about the zones of the retroperitoneal injury. Zones of the retroperitoneal injury. So when you look at the retroperitoneal injury, just for the sake of understanding, let's say this happens to be the abdomen, and let's say this is the diaphragm. So we're trying to create a retroperitoneal component here. So let's say this is the retroperitoneal space, right? Now I will divide the retroperitoneum into following components. One which will be in the central zone where you have the great vessels, that is the aorta and the IVC. Then you have the lateral zones where you have the kidney, and then you have the pelvic zone, which is going to have a collection of all that, right? So the three different zones of the retroperitoneal injuries, this is what we call it as the zone 1. The zone 1 is also called as the central zone. Now in the central zone, what do you have? In the central zone, you will have the aorta which is running. This is the aorta which is going to be running in the central zone. Along with the aorta, you will see the IVC would be running along with it, right? So the two important structures which are going to be present in zone 1 is going to be the aorta and the IVC. You can notice that this is the aorta, and right next to it you have the IVC. So the aorta and the IVC are the two structures which are present in zone 1. Whenever there is a zone 1 hematoma, now imagine if there is presence of a zone 1 hematoma. Presence of a zone 1 hematoma basically tells you that the hematoma would have formed. Here the hematoma would have formed, either the injury is from the aorta or from the IVC. Either the injury is caused by the aorta or the IVC, in a simple concept that indicates that it is an injury to a major vessel. It will continue to bleed, it will continue to expand, and the patient will continue to deteriorate. So whenever you have a zone 1 injury here, you have to take the patient for immediate exploratory laparotomy. Take the patient for immediate exploratory laparotomy. Okay? As simple as that. That is for zone 1. Now if in zone 2, what do you have? In zone 2, usually you have your kidneys, retroperitoneal space. So this is where the kidneys are positioned. This is going to be the ureter. The kidneys are going to go along with it, and this is how it is going to go. So whenever there's injury in the zone 2, so this zone, which is also called as the lateral zone, so this is what we call it as the zone 2. The zone 2 is also called as the lateral zone. They're also referred to as lateral zone. So whenever there is a hematoma, if there is presence of a hematoma in zone 2, it is usually because of kidney injury. So it is a renal injury hematoma that is going to be present. So whenever there's a renal injury hematoma, you don't need to really jump into conclusion. We'll talk about in detail. For now, you need to remember the only indication for exploration. If there is an expanding hematoma, if there is presence of an expanding hematoma, or if there is presence of a pulsatile hematoma. If there is an expanding hematoma or if there is presence of a pulsatile hematoma, either of these two, if they are present, these are the indication for exploration. This is the current indication for exploration. This is the current indication for exploration, as simple as that, right? The last one is what we call it as zone 3, where you have the hematoma here. So it's all a dependent hematoma. Either it could be a pelvic injury, or the blood from the zone 1 has accumulated into zone 3, or zone 2 blood can also come to zone 3. So the zone 3 is the most dependent zone, or also called as the pelvic zone. So this is what we call it as the zone 3, which is also called as the pelvic zone. It's also called as the pelvic zone. So whenever there is presence of hematoma, whenever there is presence of hematoma in zone 3, see, again, if there are pelvic injuries, no, they're very notorious. When I say notorious, if you try to go and dig, right, you will only cause more problem, you'll cause more injury, more aggravation of the component. So currently we all set at one single point. If there is a pelvic hematoma, that is a zone 3 hematoma, will stick to same management as zone 2. That is, if there is presence of an expanding or a pulsatile hematoma, when you put an ultrasound probe, no, you can see the hematoma which is going to pulsate, right? You'll be able to see that pulsations. You'll see the hematoma expand, collapse, expand, collapse. That indicates there's a spurt, and that indicates there's an arterial bleed, and that is what we call it as a pulsatile hematoma. So when there is a pulsatile hematoma in zone 3, that is the current indication for exploration. Now the concept is quite simple. Zone 1 injury, you will go immediately. Zone 1 injury indicates there's an injury to the great vessels, or either to an aorta or to an IVC. I am going to take the patient for immediate exploration. Zone 2, probably it's a renal injury. I'll wait and watch. If there is an expanding or a pulsatile hematoma, I will explore. The same validates for zone 3 also. That is going to be your pelvic injuries. Clear? So this is all that you should know in the context of zones of pelvic or your retroperitoneal hemorrhages as well. Okay, somebody has a question. Did I miss a question? Did I miss a question? Okay. Right, so that is it for today, guys. So today I wanted to discuss about two important concepts. In fact, one of the most important concepts in the trauma is your abdominal compartment syndrome. So we discuss that in great detail. Along with that, the zones of retroperitoneal injuries. Right. So thank you so much for joining today. I will be resuming tomorrow. Tomorrow we'll talk about again organ-specific injuries. When I come back tomorrow, we're talking about diaphragmatic injuries. We'll talk about pancreatic injuries. We'll talk about the colorectal injuries and their management. Right. Until then, thank you so much. Right, I'll see you guys tomorrow at 9 p.m. again. Right, all the FMG aspirants who are writing the exam on the 12th of January, we have another session which is lined up from 10 o'clock to 11 o'clock. That is going to be a spotters and the instruments wala component. Do tune up for that if you are writing the exam. Otherwise, go have break, have your dinner, rest well, do well, and continue to read as we continue to teach as well. So all the third year students, especially a big shout out for you. If you're in third year, you have to start the surgery early. Follow the BLS series. We will do 1 hour per day for 3 days a week. Trust me, if you continue to do that 1 hour with me, by the time you go into your final year, you would have finished your entire general surgery, that too from Bailey, from cover to cover. Every single topic, every single line would be explained in our lectures, right? So see, every single video of BLS is available on the YouTube. It gets recorded in our PW Medit channel. All that you have to do is type BLS and then you type whatever lecture you want. For example, we have done thyroid, you can go look for thyroid. If you want to look for trauma, you can look for trauma as well. Okay? So every single video is available, and if you want to reach out personally, you know where to get me. You can, for Instagram, it is the surgery guy. For Instagram, Telegram group, it is the surgery guy. It is by my name. My name only, it is Dr. Sandeep Seeram Reddy. You can look up there as well, right? Thank you so much for joining today. I will see you guys tomorrow. Thank you, and signing off. Good night.